it is difficult to get some of these specialist surgeons to some of these smaller towns. Yet at the same time, if you have a concentration of specialist surgeons in a large town, maybe here in Dallas or somewhere else, those surgeons may not all be as busy as they want to be.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management. The center is based at the Naveen Jindal School of Management at the University of Texas at Dallas. The show, like the center, brings together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare industry. I'm your host, Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management for Professionals. Today, we're fortunate to have in our studio Dr. John Mehall, surgeon and entrepreneur. Dr. Mehall is the Director of Surgery for Cardiac and Thoracic Surgery Associates, the largest independent cardiothoracic surgical group in Colorado. John is also the founder of CV Staff Solutions. More on that in a minute. Welcome to the show, Dr. Mehall.
Thanks, Bob. It's a pleasure to be here.
Can I call you John?
Please do.
I'll do that. Thank you. Well, there are many business problems to address in healthcare space, and we always want to expose the problems and explore the solutions. So to kind of set the stage for our discussion today, let's touch base on your clinical specialty and how this relates to a shortage of surgeons. You've trained over 200 surgeons in valve surgery approaches and subsequently have established quite a network of surgeons. Tell us about your background as a surgeon and a businessman and how it is operating in Colorado, west of the Mississippi.
Sure, thank you. My clinical focus has always been cardiac surgery and primarily valve surgery and minimally invasive valve surgery. And for many years now, I've run a variety of training programs, some for fellows in cardiac surgery and some for practicing surgeons who want to learn mostly minimally invasive heart valve surgery techniques and heart valve repair techniques. And it's been great, and I've certainly enjoyed it tremendously, and it's allowed me to meet a wide variety of people from across the country. Our practice is based in Colorado, and the mountain states and the plain states are somewhat unique in that we have very large geographies with small to medium population centers that are spread out across that geography, and really only a few large population centers if you really think about Denver and Salt Lake and Phoenix and some of those big cities that span the vast space between Kansas City and the West Coast.
Recently I saw on one of the Sunday morning TV channels, they had a feature on rural hospitals. And they use an example of Tonopah, Nevada, which is 200 miles from Reno and 200 miles from Las Vegas. And the hospital there is short on staff and actually shutting down. I know that when you look out at the West and you compare it to the East, where the distribution of doctors are, and more importantly, where trauma centers are for the very urgent care that is needed. I know you've looked at that as one of your businesses. I mentioned that you have started an organization called CV Staff Solutions. And that addresses some of the shortages of surgeons. Would you give us more detail on that?
Sure, I'd be happy to. There's definitely a physician shortage in the country, but even more than the physician shortage, I think one of the major exacerbators of that problem is a physician and surgeon distribution problem. And there are areas that have a high concentration of surgeons or surgical specialists, and then areas that have none. And there's a lot of reasons probably behind that. And what we are finding is that in a lot of these smaller towns, medium-sized towns, that they have trouble attracting surgical specialists, whether they're heart surgeons or vascular surgeons or what have you. And they have trouble holding on to them. And sometimes that's personal reasons. Maybe some people don't want to live in a smaller town or a medium-sized town. Sometimes it is clinical volume reasons. They simply don't have a lot of work there and not enough to maintain skills or maintain income. And that yet at the same time, those facilities need that service. Maybe they're geographically remote, like you alluded to. A lot of times there are subsequent requirements or secondary requirements, rather, to have either a trauma center or to have a cardiac catheterization lab or other things like that. You need some of these surgical capabilities in those smaller and medium-sized towns. And certainly in an emergency, telemedicine or virtual care is really no substitute for an acute surgical emergency.
So we live in Dallas here, and the word on the street is that if you are in a terrible accident, you want to go to a trauma center, a level 1 trauma center like Parkland. Make sure you get there. Let's talk a little bit about these trauma centers, because I don't think our audience is aware of the different levels of trauma centers and what their characteristics are and how that kind of fits in to the placement of surgeons and specialties.
The different trauma level designations are done by the American College of Surgeons, and the level 1 trauma center is the highest level, and that reflects an institution with every capability. And then in addition to that, there is research, resident training, and other things going on. And those really are the academic medical centers such as Parkland that you alluded to. The more commonly found trauma center in medium-sized or larger towns is what's called level 2, which has the same clinical capabilities as a level 1 trauma center, but does not carry on research or resident training functions. And then in smaller towns, there'd be a level 3 center, and then there's even one below that. And the kind of big fork in the road is between level 2 and level 3 is the on-site capability for cardiac surgery, neurosurgery, and some of those surgical specialties. And certainly there is a clinical advantage to having all those kind of skills and capabilities for the patient under one roof. But for the hospitals, there's also a financial component to that, because as hospitals attain these designations, they get a change in their reimbursement, and you can have significant increase in your reimbursement for all procedures if you attain a level 2 or a level 1 trauma certification. So for some hospitals, especially if they're a medium-sized town, if they're able to attain a level 2 and maintain a level 2 certification, they're going to get an increased volume of ambulance traffic, not just of trauma, but of all types of patients. And then for each of those patients who are admitted, they're going to get a slightly higher reimbursement. And so for the hospitals, it can be have a major financial impact.
So what I'm hearing is that if you are not a level 2 trauma center, and you do not have the appropriate surgical staff to provide these types of services, you'll miss out. You could be a level 3 with these services and move to a level 2 over time. And so that's really an engagement enabler for the hospital being staffed appropriately.
Yeah, there's a major advantage to the hospital to have those services. Most of the times, those types of specialty services in and of themselves have good reimbursement and can enable the hospital to make money that they can then use to supplement other services that they're providing that maybe are not as profitable. It will also drive ambulance traffic, and then on a per admission basis, they often get a better reimbursement rate. And so it is a big fork in the road for some facilities between financial sustainability and not, especially in smaller and medium-sized towns.
Okay, so the problem's pretty well identified. There's a shortage of surgeons. These surgeons can be utilized in these remote trauma center areas. What's the magic wand? How do you find these qualified surgeons that can go in, and how long do they stay, and what professionalism do they expect? What are all the details around that business?
Sure. I think the challenges that those hospitals face is they often have difficulty recruiting people to those locations. Not everybody wants to live in I don't want to pick a town and pick on them, but not everybody wants to live in a medium-sized rural town, but everybody wants to live in Dallas or Chicago or something like that. And that's challenging. And so sometimes there's recruitment issues. Their volume of clinical work is probably not going to be as much as they would have in a larger demographic population, simply because the denominator of people is smaller. If you have a smaller population and only a certain percentage need that service, then you've reduced the number of people that are going to require the service. And so there may be challenges in maintaining clinical skills. And obviously, if you're doing a lower volume of work, that may in some situations translate to lower income. And so it is difficult to get some of these specialist surgeons to some of these smaller towns. Yet at the same time, if you have a concentration of specialist surgeons in a large town, maybe here in Dallas or somewhere else, those surgeons may not all be as busy as they want to be. And so what we have found is at least in my world of heart surgery, it's not a large population. There's about 3,500 heart surgeons in the U.S., and so you do tend to get to know each other over time. And we have found that there are people who live in a bigger city and who have a practice but still have excess capacity that is underutilized and that they have interest in utilizing. And we are able to marry up those surgeons who have excess capacity to go to a smaller town where they have a need, and then they can fill that need in the smaller town on a part-time basis. And that's kind of what we have started doing over the last 5 or 6 years.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
So if I'm a surgeon here in Dallas and you would find that I have capacity, I would go away for a week or two, a month, a year. I mean, what's the assignment?
In general, most of our surgeons work about 7 to 10 days a month somewhere else and then are at their home location the balance of the time. Some people do work longer stretches, but most of them are generally a week at a time, and that's kind of a balance of maintaining their other practice and maintaining some home life and a balance there as well.
Would that be a repeat, rinse and repeat, do this at that particular location on a regular basis? Or would it be, I'm going here 1 week and next month I'll go somewhere else?
No, we definitely don't want to send people to different places every month. And what we have found is once we have a facility who contacts us and has a need and they are looking for a certain amount of help, then we will have 2 or 3 surgeons who we think would be good fits for that practice and who have an interest in going to that location, go there. And usually 1 or 2 of them find that it's a mutual fit between facility and surgeon. And then at that point, we generally would send the same surgeon back to the same facility for at least a year, so that that surgeon gets familiar with the team there from a clinical perspective. They develop working relationships with everybody in the operating room that they're going to do surgery with. The people who are referring patients for surgery get comfortable with them and comfortable with their skill set, and then it really becomes a very stable situation where it's business as usual, and it's not any different than if the regular person who's there the balance of the time is there.
Very good. So kind of like Airbnb, where you can basically share your house, or they have car rentals now where you can share. You're kind of set up an established methodology here where you can share the capacity of doctors and apply them where they're needed then.
Yeah, it is very much where the surgeons tend to work and practice where they already were, but they had extra time and they desired extra income. And then we found a reproducible place where they can go and work for a portion of that time. And the work is steady, and the work is with a group of people that they become familiar with. And then it obviously supplements their income and fills the need of the facility.
So within the medical community, there are terms that we're not familiar with, and so our audience may not have heard the term locum tenens. Locum tenens, it's Latin, I believe, and it means a holding place. And the connotation for local tenens may not be the most positive. It might have a different association with it. Explain what that means and how that is not what you're doing.
Sure. So locum tenens has been around for a long, long time, and traditionally, it was thought of as somebody who couldn't hold down a regular job. And that's very different than what we're doing, in the sense that most of these surgeons that we're working with are doing this on a part-time basis, and they often have other jobs. But there's also been a shift in how everyone is working, but especially within the medical community. And we see more and more people that are choosing to work part-time, either to accommodate a spouse and their career or to accommodate other interests that they have, and maybe they want to travel. And we see this where somebody may live in a certain location because their spouse has a job there, and there might not be a viable practice there. That market might already have enough doctors of that variety, or they want to work part-time to balance family issues and work with their spouse, and so that the two of them together can be home with kids or things like that. And so there's many more people that are working in this part-time basis, and they may or may not necessarily be living in the place that they're working.
So, John, how do you see this business scaling? Is this a new trend, especially in the surgical area? How do you think this grows into the future?
I think it's actually, we're experiencing a tremendous amount of growth. We've been doing this for almost 6 years and continue to grow year over year tremendously. And we are now, we've been doing this in cardiac surgery, and it's grown to vascular surgery and other cardiovascular specialties. And we're also starting to see it now as in neurosurgery, trauma surgery, and we're expanding the scope of what we're doing. And we're also seeing, historically in our business, we had seen a small hospital or medium-sized hospital that employed one specialist, and then we would come in and provide them 7, 10, 14 days a month of supplemental support and coverage for their one employed specialist. And now we're having institutions ask us to take over the entire service line and coverage because they can't even find and hire the one specialist. And so they're asking us to come in and provide them 2 or 3 physicians to cover the entire service line now. And so there's definitely growth within the cardiovascular services and within other specialties as well.
Yeah, I can see that. I think we're all aware that change in healthcare is imminent. It's happening more and more every day. Being innovative, finding new ways to take advantage of resources and people. As the West populates and grows, I could see that being as an increased volume of business as well as people start to distribute out through the country. With all the new healthcare changes on the horizon, there's always a need for the properly trained surgeons and physicians. The customer experience on this it's got to be pretty good too with the patients.
Yeah, I think the patients should see it as seamless care because we're having a provider who's comfortable working in that system, comfortable working with the team of people, whether it's anesthesia, perfusion, physician assistants, nurses, et cetera. It's not somebody different every week, which that is not a solution. That's simply a placeholder. At some level, the hospital has to have somebody on call. And so if it really breaks down to that, that's what they can do. But we really see this as more of a practice solution so that the patient experience should be seamless the whole time.
So you're an entrepreneur as well. I mean, obviously you're a surgeon, quite well known for your trade. How did you get into the idea of being more business-oriented as opposed to just being a heads-down surgeon all the time?
I think it's like a lot of things. It was serendipitous. And so I am running a large group in Colorado, and we had several surgeons who were at the point where they had their children out of high school. They wanted to slow down a little bit. They had the flexibility to travel. And at the same time, we were getting a lot of calls to our group for help in covering different things. And so some of my partners and I would go somewhere for a week. And then that kind of just grew and grew. And then it morphed into really a much more formal business, which we incorporated a number of years ago. And then it's grown steadily since then. And it's grown because it really resonated with the providers. So people who had excess capacity and weren't as busy as they wanted but didn't want to move could get busier, do more clinical work, increase their income. It resonated with the facilities because we're able to fill needs for them that they couldn't fill themselves. And we're able to do it in a way where we have intimate knowledge of the providers, just because it is a small community and we're able to vet people. And we're also able to look at the facilities and and understand what their capacity is and what they might need to do this well. Sometimes people will call us and they won't have all the pieces in place to do this successfully, and we end up having to help them get the right pieces in place so that if we do put a surgeon there, then that surgeon has a good chance of being successful and the patients have a good chance of doing well, as opposed to just plopping somebody down for the sake of plopping somebody down. And so that's a different approach. And it's because we have intimate knowledge of what the facility needs and what the surgeons need in order to really deliver good care.
At the university here, we have a program that deals specifically with doctors, and now we have some doctors that are millennial doctors. They're born in 1982 or later. Is this something of interest to a younger doctor? You mentioned earlier that a lot of the close to retirement doctors see this as a great opportunity. Does this have any pull at all for maybe the younger generation coming in?
It absolutely does. I think you have to have a little bit of experience in order to do this well. I don't think it's something that somebody right out of training could do. But once people have some experience, it definitely appeals to a lot of them. We have several surgeons that work with us whose wives, ironically, are both dentists. And so their wives have dental practices, and they're pretty well established. And these gentlemen work 10 days a month each, and we generally they go to the same place every month. And it's a great way for them to maintain their skills, maintain time at home with their family. And maybe they don't have an income requirement to work at full time because their spouse is working, et cetera. And so it is a good fit for them, allows them that balance. And the other thing that we've seen with the younger generation is most of the younger generation has never been in or founded and run a private practice model. And when we go to these facilities, usually the facility has been through some tough times. They've struggled with recruitment, et cetera, and they don't really have a functional operating practice structure. And then if they're trying to attract a younger generation surgeon there who hasn't built a practice, hasn't put all those pieces in place into an operational framework, then the ask of them to come there is even higher, because not only do you need to go there and do the clinical work and build the relationships and build the referrals, but now you also have to build a functional practice platform in addition to that and train up the OR team and train the PAs and train everybody else. So by having a fully operational functioning platform already in existence at the facility, it makes their recruitment of a younger physician and a younger surgeon much easier.
Well, it's really great to see innovation taking place and a fresh look at modern healthcare today to the eyes of someone who's been there and seen a few things. So, John, we're so glad to have you on the Business of Healthcare podcast today. Thank you for your time, your insights. I think this is going to open the eyes to a lot of other possibilities in healthcare for us. We certainly appreciate it.
Thank you, Bob. I appreciate being here, and I appreciate the podcast that you're doing.
Thanks for listening to the Business of Healthcare podcast. Join us online at businessofhealthcarepodcast.com to find episode links, notes, and more. Be sure to subscribe to the Business of Healthcare podcast on Apple Podcasts or your favorite podcasting app. To learn more about the Center for Healthcare Leadership and Management, go to jundal.utdallas.edu and then search under the Center and Institutes tab on the navigation menu. Also, we want to hear from you. If you'd like to provide feedback, make suggestions for future guests or show topics, or just want to get in touch with us, email us at healthcarebizpodcast@utdallas.edu. Biz is spelled B-I-Z. And let us know how we're doing. I'm your host, Dr. Bob Kaiser, with the Center for Healthcare Leadership and Management, where we're leading change by changing how we lead.